Hi everyone, this is Alex from Salmonella Place. Right now I'm going to give you a pharmacology lecture on the respiratory tract. So the first thing I want to talk about for this topic is bronchial asthma. This is increased tracheobronchial sensitivity. Now, some of the symptoms that you will experience if you have this disorder is smooth muscle hyperplasia in the airways, otherwise known as bronchospasm, mucosal thickening or edema and cellular infiltration, mucosal gland hyperplasia and mucosal plug formation, recurrent coughing, breathlessness, chest tightness, and wheezing. If you have a mild case, you might experience allergies, an extended cold, and you will feel the symptoms when you exercise. However, if your case is more severe, you will experience wheezing and possibly dyspnea during normal activity. So just before I go on to talk about the drug groups that are used with the respiratory tract, I just want to mention the types of drugs. Now, most of the drugs are swallowed and absorbed intestinally. However, in this particular topic, most of them are inhaled in the lung tissue. Now, of course, the absorption depends on the lipophilicity, but when they're inhaled locally into the lung tissue, there are less side effects, and there are also minimum systemic side effects. So that's quite important to remember when you are prescribing drugs for your patient. You want to help them without creating any major side effects or ones that will affect their entire system. Anyway, let's go on to the first group, which is the bronchodilators. These are otherwise known as beta-2 agonists. Now, what they do is increase the cyclic AMP, and this causes relaxation of bronchial smooth muscle. They work for about 4 to 6 hours, and they can be inhaled or given as an injection subcutaneously or through IV. There are two subgroups of bronchodilators, specifically beta-2 agonists. They are short-acting and long-lasting. The short-acting ones are terbutaline, salbutamol, albuterol, and phenterol, to name a few. The long-lasting ones are formoterol, salmeterol, and these ones are inhaled and they're for prophylaxis. Some of the side effects of this group of drugs include vasodilation, which can lead to hypotension, causing reflex tachycardia. It also increases the blood glucose levels and increases gluconeogenesis. They can cause skeletal muscle tremor and tolerance of the beta-2 receptors, which mean they're downregulated. Now continuing with some other bronchodilators, I'm going to talk about theophylline and aminophylline. These are natural alkaloids. They cause bronchodilation and mast cell stabilization. They also inhibit phosphatase. They stimulate the respiratory center in the brainstem, and they sensitize it to carbon dioxide because asthmatics have hypercapnia, which causes desensitization. They also increase diaphragmatic contraction. They are used as a prophylaxis. They last for about 12 hours and have a slow release. They steady the plasma concentration. Now, adenosine, which inhibits cytochrome P450, does have quite a few side effects. That's why it's not used now. Included in those side effects are toxicity, central nervous system excitement, headache, tremor, convulsions, arrhythmia, tachycardia, vomiting, and increased gastric acid secretion. It also crosses the placenta and the blood-brain barrier. Now that we're done with the bronchodilators, I'm going to go on to the next couple of subgroups of drugs for the respiratory tract, and we're going to start with the muscarinic antagonists. These include ipratropium and tiotropium. There is no absorption in the lung, but in the GI tract because they're hydrophilic. However, there are no major systemic side effects. The mode of action is the inhibition of acetylcholine-induced bronchospasm, and these are commonly given with beta-2 agonists. Now, the sodium chromoglycate and necrodomil, which are used in prophylaxis, these are mast cell stabilizers. They're hydrophilic, and they have, as the previous group, no major systemic side effects. However, they are inhaled instead of ingested. And the last subgroup on this slide is the anti-lefkotriene drugs. These combat the lefkotriene C4, D4, and E4, which cause bronchoconstriction. The drugs used are zafirlocast and montelukast, and they are lefkotriene 1 receptor antagonists. There are no major side effects. The next drug group is anti-inflammatory drugs. These are inhaled steroids called glucocorticoids. They are used for prophylaxis, immunosuppression, and of course against inflammation. The drugs include belcomethasone, budesonide, and fluticasone. They have a high first-pass effect and no systemic side effects. The local side effects, however, include fungal infections in the throat, dysphagia, and beta-2 agonists are given with them. The mode of action alters the gene expression. Again, they are used for prophylaxis. However, if they are given long-term, they can cause osteoporosis. Now I'm going to tell you about the last 3 drug groups. First one is antitussives, otherwise known as cough suppressors. So they suppress the coughing reflex. They're usually used for a dry cough, but if you do have a productive cough, they can be prescribed to remove the secretions from the bronchi, which is the mucus. They are usually opioids, the non-addictive ones, for example, codeine, which is a natural opium derivative. However, it does have side effects including constipation, mucus retention. That's why we give dextromethorphan, which has less side effects. The next one is expectorant agents. These increase the bronchial secretions, but decrease the mucus viscosity. So it's creating a less thick mucus, which can be gotten rid of easily. However, they do cause vagal stimulation, and they increase bronchial and gastric acid secretions, so the major side effect is vomiting. The saline expectorants are sodium iodide, potassium iodide, and ammonium chloride. And lastly, the mucolytics, such as acetylcysteine, decrease the molecules in the sputum but increase their viscosity. The mode of action is to inhibit the disulfide bonds in the mucoproteins. So guys, this is the last slide about the respiratory tract, and I'm just going to tell you about the most frequent disorder in which you would prescribe drugs, which is allergic rhinitis. So first you would give antihistamines, cetirizine and loratadine, then nasal decongestants or alpha agonists like xylometazoline, nasal corticosteroids like budesonide and fluticasone, and mast cell stabilizers such as sodium chromoglycate.